Welcome to Marney Reid Presents Connect to Develop, where we provide insight from healthcare leaders on the hottest topics and trends. I would like to introduce you to Janet Carlson, Executive Director of ASCs for Commonwealth Pain and Spine. Janet is not only a subject matter expert in ambulatory surgery centers, but she also has vast knowledge of building out a concierge medical practice. Janet, thanks for joining us.
Thank you for having me, Marnie. Excited to be here.
Absolutely. So before an orthopedic surgeon can even begin to build a concierge medical practice, can you walk us through what this exactly means from a surgeon perspective and how will their current practice change?
So this is another type of patient subset that the surgeon is going to want to bring into their practice. This is different from a patient acquisition perspective and how you approach this. And it's not traditional the way that we now schedule patients via referral systems or self-referral. This is something entirely different. It's changing the face of medicine as we speak about it today.
So when you talk about a different patient subset, can you unpack that a little bit for us?
Definitely. So these are people that are very invested in their health and their activities of daily living. These are people that are searching outcomes and are looking for the best opportunity for an excellent clinical outcome that's going to impact their life in the most positive way. And the internet, of course, and today's technology is allowing patients to look up outcomes. They're looking up physician reviews. They're also looking to see those physicians that are considered key opinion leaders in their space. And they're also looking for an experience that is a lot more personal and individualized to their need.
I love that word bespoke and very apropos. So these patients are coming in a lot more informed. And so in terms of how that goes in clinic, if the typical patient comes in, are they spending less time in clinic? Have they come in? Maybe is it even a second opinion by the time they get to a medical concierge practice? Tell me a little bit about what that patient visit looks like.
So I'm glad you asked that question that way, Marnie, about the second opinion, because often that is the impetus to bring these patients in for another perspective, another visit, like I said, where they can be assessed. They can speak in person with a physician if possible, or use virtual meeting links, and where they can review their imaging and labs and other diagnostics. And this is a practice where you can bring the patient in, spend the time with them because they want that very individualized, patient focused approach. And so this is your opportunity as a provider to give them that attentive care.
That sounds very intriguing, especially as someone who might need a total joint replacement or God forbid a spine, surgery at some point in the future. I understand how it would be popular in socialized medical countries, but in the United States specifically, are we seeing a bigger trend in these types of patients and especially for musculoskeletal elective procedures?
Definitely. And so, with the demographics of our community in the United States specifically, Marnie, we have the baby boomers, and they are obviously a very large demographic just by the nature of their age. They are demanding a higher quality of life. And they are also savvy consumers, and they are looking for something outside of what they believe would be the traditional total joint experience, for example. And they don't want to do it with just their Medicare allowable in an inpatient setting. I think they are much more amenable to an ambulatory surgery center option and a concierge option that they're willing to pay for outside of their Medicare allowable. So that's one demographic that is specific to the United States. The next demographic that will be coming up will be the Gen X generation, who will be even more demanding, in my opinion, than the baby boomer generation about wanting to live their best life, be able to stay fit, active, involved, with their workouts, their hobbies, their families, their travel, the vacations, that sort of thing. And so there's going to be more opportunity for surgeon physicians to focus on this type of model to provide care to this unique patient population.
As soon as you said Gen X, I immediately had this meme pop up in my head of, that's just not part of my journey. I almost see a t-shirt, concierge medicine, it's part of my journey.
I think that's
Oh,
wonderful. I think that's a great image that you paint.
you
I love it.
heard it here first, folks.
That's right.
Um, let's start with the skill set, the brand, the reputation, the niche. If this is trending and if there's going to be even more opportunity, as you're saying, through the baby boomers, which is a large generation, the Gen X. So
Yes.
what does a surgeon need to start doing to develop it? Because you don't just suddenly one day go, okay, I'm open for concierge. So can you walk us through, the skill set, the brand, the reputation, the niche? You said they're researching, they're looking for KOLs. How does a surgeon begin building that now?
I think as a surgeon is contemplating this model, Marnie, the one piece of advice I would lead with is that they need to be hyper focused on if this is going to be a complete paradigm shift for them, then are they going to be doing this 100% of the time? Or is this something where they're going to approach it via a hybrid model? Are they going to blend their daily direct primary care in their clinics with also an addition of a concierge model? So I think up front, the physician needs to understand how they're going to practice and what that looks like. And what does good look like in a concierge only versus a hybrid system setup? So I think the physician needs to know, are we going to start trying this out and then slowly organically grow it? Or are we going to go ahead and jump right in because the need is so great and the trending on this is so high that there's tons of opportunity for surgeons that are willing to do the homework, invest the capital up front, do the marketing, and then have their infrastructure ready because you want to implement what you're getting ready to start, and you want to do it well right out of the gates.
You mentioned infrastructure. Let's stay on that. What added pieces of infrastructure or adjusted pieces of infrastructure are going to change when a surgeon starts building out this concierge practice?
I'll give you some real life examples of physicians that I've worked with. One basically decided to leave their lease in a facility that was a little dilapidated, where the landlord had not kept up with the building, even though the tenant had on the interior. And they decided to relocate to the bottom of a condominium complex where they actually had ready built in potential patients right there in that demographic. So a physician and the rest of the practice relocated their office to a high end. It's going to cost more for their rent, but the return will yield the margins and the revenue that you're looking for to sustain this model. So that's one physical example of moving your practice to where you have a facility that doesn't really look medical. It looks very welcoming and warm, earth tones, lighting, music, where it's more like you're having a conversation with a patient in a living room or, a comfortable den than you are a typical exam room, with all the aesthetics of more of a medical office. So that is an example of somebody that said, I'm going into this 100% and I'm going to spend the money and the time to build it right so that people have access to my very, comfortable, patient accessible office.
Had this surgeon had patients come in asking for this experience? I mean, how did they know, A, that the rolling the dice like that would pan out, and B, how did they pick this specific complex, that marriage between it's open, it's available, I can afford it, and there's patients there? I mean, what kind of research did this surgeon do, or their, practice manager, in advance?
They did some market testing. They spoke to their patients along with their nurse practitioner, the physician as well. They started identifying patients and asking them 8 months ago or 8 months prior to when they went go live if this would be something they would be willing to hear more about, learn more about. And as the patients that are their routine patients said, absolutely, we would love to know more because we'd like to have you considerably more available to us than you currently are. It's very difficult to get appointments the way that you're currently set up. And so they just softly tested the market that way, just with their own patient population demographic, and decided to go ahead and make that investment. Like I said, and they targeted the demographic, which is the baby boom generation that happens to live in the facility where they're housing their new office. So literally just can come down to the first floor and come visit the physician, which is outstanding, I think, from an, logistics perspective. Another thing that this physician did that I know that it was very highly received is that they worked with the owner of the building to use their public spaces to hold a welcome, informative meet and greet session with all of the residents of the building. And it was an invite only to the residents where they presented who they are, what they do, the services they offer, the fee structure. And it was genius, Marnie, because they said to this targeted market that this is going to be available to our current patient base that is, and they gave a number, let's say 4,000 patients. We're going to offer this to our existing patient base of 4,000 patients beginning July 1. However, if you all are interested to sign up for this, we are accepting new patients and we're going to cap new patients at a certain number. And so I was able to witness how immediately after the presentation of the meet and greet to the residents of this location, where potential patients came up to speak with the physician, the nurse practitioner, the office manager, and inquire about when they could come. And some literally came the next day, Marnie. And it was also interesting to see that it wasn't just individuals, it was couples where significant others were coming, and they just loved the idea that they're going to have a, completely focused physician available to them that's there at their behest should they need it. And so that is an example that I've seen executed beautifully.
Genius. They created scarcity.
From the beginning,
Yeah.
and they are truthful about offering it to their patient base, but they're
Yes.
saying if you would like right now to come and walk in, no appointment needed, a meet and greet, get to know you. They have an intake form. They have a fee structure for membership that they share. And then here's our office administrator that can help you get in our database. And so it's been beautiful to watch because they immediately created demand and the feeling of the concierge carve out, if you will, that this is something that is somewhat of a luxury, if you will.
Absolutely. You talked a little bit about access. In a concierge practice, does the physician, is two questions actually. Does the surgeon have less patients because they're able and they need to dedicate more time to those patients, but because they're not dealing with the rigmarole of insurance and collections and all of the, pre-authorizations, they actually can afford to have less patients?
Correct.
And then on the other side of this, do they bring any non-op medical physicians in with that? Because I have to assume that if the members are paying for more access, a lot of it is non-operable, and so there's ways that you can utilize other clinicians
Yes.
for that care.
Absolutely. So, all good questions. And the way that I have seen it work well recently is that they are able to juggle, if you will, a smaller patient base because of the fees that they charge. And if they charge it either as an annual fee or they break it up monthly, but they have agreements in place. And so they're able to amortize out how much they're going to anticipate in revenue monthly so they can cover their operating expenses, pay themselves, and know when they're going to cap the number of patients they see because they don't want to miss any service opportunities. They want to focus on that catered aspect of taking care of their patient base. And so they can technically handle less patients with a greater focus and still generate revenue and not have the overhead, like you said, Marnie, of the people that are doing pre authorizations, coding, billing, arbitrations on the back end, revenue cycle. You get to reallocate those resources to, I would say, having a PM&R doc, a physiatry doc available to help with injections and things like that can be done in the clinic.
I love that. Expand a little bit more on the services, and this makes sense, right? If you already have a patient base coming in, surgery isn't the only option,
Mm-hmm.
adding physiatry, PM&R.
Mm-hmm.
What other services might you find a concierge surgeon with concierge medical practice surgeon offering that they might not do if they mostly have their standard mix of, Medicare and commercial patients?
Some I know have referral relationships with chiropractors along with physical therapy. They have that available as well. When offering concierge medicine, you can begin with the provider, advanced practitioner, for example, with orthopedics, physiatry, pain management, physical therapy. If you don't have the infrastructure at the beginning to have some of these additional treatment option providers under your roof, it would behoove you to establish those relationships up front for a referral for a very similar high touch concierge bespoke feel. I know a lot of physicians that start small and grow, and as they have different demands and needs, then they will add it to their practice.
Very strategic. What role does an office-based procedure room and or ASC, especially for orthopedics, play in this?
I think it's a great combination to have the clinical office, even a procedural suite with imaging available on site to include plain film x-rays and MRI. And then in the procedure room, you can have fluoroscopy and you can also have ultrasound guidance so that you can give these patients the steroid injections or some of the different injections that they try in their joint prior to having a joint replaced. You can do some of the required diagnostic and therapeutic injection workups, for example, for an SI joint fusion for somebody. You're trying to ascertain, is it their SI joint or is it their L5 S1 lumbar pain with that's radiating to the SI area. So if you offer a suite where you can examine these patients, image them, potentially conservatively treat them with evidence based best practice medicine. And then if it does come to the time where the patient, is bone on bone with osteoarthritis and they know that they'd like to live a much better quality of life and they need a new knee or a new hip, when they decide that's the route they'd like to go, having accessibility to an ASC is an elegant part of a solution for providing that concierge level care to a patient.
As a patient, personally, being able to go to a doctor and having all of this, there's been a couple of instances, not a lot, but a couple where I've, gone in and they want me to come back or go to a completely different place where I
Mm-hmm.
then have to schedule it, just so they can continue seeing, the care pathway. And my initial thought is, I don't want to do that. So having all of that on site is great. What's the realistic time frame from when a doctor decides they want to start, doing that market research and talking to their patient population? I mean, you mentioned 8 months for this one surgeon.
hmm
Realistically, from a national level, if we've got some physicians out there in practice wanting to, start beginning this, realistically, what can they look at as a time frame?
I would target a year, and I would say that they would need to start immediately on identifying what their brand is going to be, and then work with somebody that specializes in healthcare marketing and branding to help them create this new logo, this new name, this new look, and then begin with all of the content ahead of any rollout so that when you are talking to your current patients to ascertain if they would like to join, you want to make that benefit available to them, then you could even hand them a glossy pamphlet. You could give them a QR code that they could scan that will send you to your new website where they can have the paperwork there, the sign up online. They don't have to come into the office in person to sign up. They can come in for their first visit if you'd like. The meet and greet established visit where the physician, surgeon, and the patient talk about the patient's goals and their lifestyle and their needs so that the physician can provide that best level of care.
To that point of, signing up online and then coming in, I have to assume that the way that the staff works and interacts with the patients and everything and just the flow has to be a paradigm shift too. What are the key stakeholders in a clinic for a physician that need to, come on board to champion this? Because it's great that the surgeon has the capabilities and wants to do this, but everything lives and dies in execution. And I have to
Mhm.
think that their clinic support staff is critical for this.
It is. You need to have a practice administrator that's fully on board and is willing to help manage this for you, this new business model. I would also recommend, Marnie, having a nurse navigator, specifically if you are a physician that is going to be performing many surgeries. The nurse navigator can help handle a lot of the pre assessment patient optimization prior to a surgery, for example, for a total joint, and can also be a resource for the patients to call with medication requests, questions about their lab results or imaging results. A lot of times, the nurse navigator can help the physician and any advanced practitioners communicate with the patients and be that go between. So, I would also recommend adding a nurse navigator. If you're going to have the imaging services on site, then of course you would need the licensed individuals capable of operating C arm, an MRI, magnet, x ray, how to do all of that in office so that you could then have those images available right then to look at those, speak with the patient about them. So you would need radiology support. You would also need support if you had a procedural suite and an office based lab where you would need somebody that could help you if you needed light anesthesia, if you're going to use a CRNA for propofol, or maybe a nurse with ACLS that could do nurse conscious sedation, max sedation, that sort of thing. Or you're just going to have somebody that can help you basically circulate little small quick case in a OBL procedure room.
This is incredible. And it feels like most physicians probably have a lot of this. They just haven't per se organized it this way or
hmm
really streamlined. Let's talk about cost because you said one of the first things you want to do is, put together the marketing
hmm
collateral and putting together the payment fee schedules. How does a physician stop and assess their end-to-end costs without missing any, right? So that they make sure that they're meeting the market where they can afford it, but also they have to make enough to be able to continue to build on services and to make it worth this whole change.
So, obviously, if they're going to relocate to new digs, the cost of that, making sure that you're budgeting for that. And if you own the facility or are you leasing it, you have a triple net lease where you're going to have to be required to do tenant improvements. So, I would accrue for that monthly. I would also consider the cost of the equipment you're going to want to have. This is a one time capital expenditure, and I would recommend you get those with warranties. Even if it's gently used equipment, I would make sure that you have warranties available and specialists there to do preventative maintenance on all of your high end, very expensive equipment. And then you're going to also have to consider what your FTE count is and what you're going to need to have to net, well, gross actually, so that you can pay for wages and salaries.
That sounds a little bit daunting at first, but I think if you just sit down probably with someone really good in, the finance department and figure that out. And I guess you can also add a la carte services,
Mm-hmm.
if do end up buying those extra things and you can kind of
Mm-hmm.
pull your patients and all. I kind of equate it to, if you join a country club or whatnot and they want to, make some changes or do some things, kind of an assessment and everything.
Yes.
So
I
what
think
would you say? Oh, sorry.
No, I think a financial partner is integral to success from the beginning. They can help you with the way that you allocate cost. They can help you with capital expenditure planning, how you depreciate things on your P&L. So definitely having somebody strong in the finance department to help you navigate the expenditures and then forecasting for revenue is imperative.
What are I would say, from what you've seen, because I know you're always at various different conferences and you're always learning from people and sharing best practices. By and large, what have you seen be the biggest holdups for success when surgeons start to try to go into the concierge medical practice from their current state?
I don't believe they have the total infrastructure for this well thought out and already established. I think some physicians I've seen do it where they say, okay, I'm going to offer concierge medicine, and then realize after hitting that button that they don't have a way for their patients to get in touch with them that is outside the quote old way of calling the office or logging in online. There's accessibility issues right out of the gate. So these patients expect unlimited access to their physician, right? And they don't want to have to wait. They'd like to know, if they can't call and speak to him, perhaps there's a way that there's a platform, a software application where they can text their physician and or nurse practitioner, PA from the practice where they can get an immediate response. Are you able to refill their prescriptions? And what does that look like? Because you're used to doing it in the EHR at the hospital or the EHR you're affiliated with at your clinic, and it just pushes to the pharmacy. So some of these things haven't been thought through, and it then helps cause frustration for the surgeon and for the patient population if all of these little nuances haven't been anticipated and planned for.
I can imagine the frustration on both ends. From the success standpoint, both from, I assume that the patients are happier, they feel
Mm-hmm.
much more. I really like that individualized because that's so key,
Mm-hmm.
especially too with, people being so impatient with, I want it now and I want it, exception.
Yesterday.
Yeah, yeah. So what are some of the best things that you see from a surgeon and their staff perspective when it's successful?
What I see that I notice immediately, Marnie, is just it looks like a burden has been lifted from the shoulders of the surgeon and their team because they're no longer chasing after the RVU model. They're no longer feeling like they're on the hamster wheel, that they are now in charge of their own practice and can practice autonomously. That is a tremendous shift in their mindset. and the freedom of that affords for them to be so service focused on their patients and actually making decisions that are patient centric. It's amazing to see the transformation. Additionally, it removes the frustration they have of the coding and billing game and the payer pre-auth game, where, right as they are preparing for a surgery, we all know this, Marnie, they're getting ready for surgery, and then all of a sudden, surgery is going to be held up because you have to do a peer to peer now with some random physician working for some random insurance company who has no expertise whatsoever in what you are doing, and you're trying to plead your case the day that you have your patient there ready for surgery. It's the comedy of the absurd. And so, not having to deal with payer negotiations, not having to deal with the declining reimbursements from CMS, Medicare, Medicaid, which again is a race to the bottom, the freedom that it affords these practitioners, surgeons, is incredible. I just have watched them blossom, and they're so fulfilled, and they're so excited to show off their practice model to their peer colleagues because, they're a living testimonial of success.
I love that service focused and more patient centric. And I think that has to really resonate with all of our physicians out there. Well, Janet, this was incredible. There is probably going to be a request to do a part 2 for this, and maybe even specifically look out. I can imagine surgeons calling in saying, I'm a such and such subspecialist and I want to learn how to
Absolutely.
do this. So, for everyone out there listening, thank you. And also, if you'd like to learn more about Janet and her experience and how to connect with her, please check out her bio in the show notes.
Thank you.
Thanks for listening to Connect to Develop. You can find more interviews and Marnie's Minutes on my YouTube channel at Marney Reid Presents.